Black Doctors Podcast.
Hello and welcome back to the Black Doctors Podcast. I am Dr. Stephen Bradley, your friendly neighborhood anesthesiologist, medical ethicist, host of the Black Doctors Podcast. I am back for another episode. This is, I guess, the last episode of this year. So we're coming to the end of 2022. This will also, I guess, be the last episode in season 6 of the Black Doctors Podcast. Thank you for listening and tuning in to our 6th season on the air. I wish I could say I was bringing something crazy, new, and inspiring and fun for season 7 and for the new year, but to be honest, I am drowning in fellowship at the moment. I came back after practicing for a couple years in the Navy to complete a fellowship in critical care medicine, and it's been a super busy month. In December, I've been in the cardiothoracic ICU. We've had a huge census, a lot of super sick, critically ill patients, a lot of transplants and other stuff going on. And on top of that, been interviewing for jobs and have barely managed to continue to put these episodes out. But fortunately, it's worked out every Monday, a new episode of the Black Doctors Podcast has come out. So we're just going to keep maintaining, and once I am done with this training, so by June, I'll have a lot more time to dedicate to the show and, get back out there with some cutting edge stuff, get the marketing game back up. So say once again, thank you for joining and listening each week and supporting the show. We'll hear a quick word from our sponsor and then jump into today's episode.
This podcast is sponsored by Picmonic. In 2011, 2 medical students came up with the ingenious idea to combine medical education with unforgettable characters and ridiculously memorable stories. Featuring over 35,000 high-yield facts and graphics, Picmonic has helped over 600,000 students improve exam scores and perform better clinically. Picmonic has resources for pre-med and medical students, as well as other healthcare professions. Check out the show notes for a link to their website. Mention the podcast when you subscribe. With Picmonic, you can study less, but remember more.
So this past week, there was an article that came to headlines, kind of blew up on Med Twitter, and it talked about something that happens in a bunch of different hospitals across the country. We've all probably experienced something like this to varying degrees, and it will affect us all in how we continue to practice medicine. This episode is going to be more of the medical ethics varietal, and we're going to talk about this article that was entitled "Major Trustee, Please Prioritize." That's in quotes, and how NYU's ER favors the rich. This was published in the New York Times. It talks explicitly about the emergency medicine department at NYU. Everything that I say or mention will be in the article. Don't sue me. I'm not making assumptions or accusing NYU of anything. I'm just kind of using this article as a launching point for today's conversation because I think it's relevant to a lot of the things that we see in practice of medicine. As we get started, you can visit our website, www.theblackdoctorspodcast.com. You can click on the share the mic link to add your voice to this conversation, which we'll probably add in like a follow-up episode or whatever. And you can answer the question prompt, basically asking about what's your experience with VIP patients, how do you treat them, and if you have any anonymized stories you'd like to share. So it's not likely a foreign concept to many of us, especially depending on the hospital system you work at. I remember some hospital systems I've worked at. You'll have the gold bar in Epic, yellow bar, whatever, and it signifies that this is a VIP patient. Who determines that is up to the individual hospital system, but typically these patients have donated a lot of money to the sum of millions of dollars. These patients are related to hospital administration or university administration, or just some high-profile visitors. Maybe they're famous, they're actors, they're athletes. And you have that designation on their chart saying that they are a VIP patient. Depending on your role in the healthcare system, if you are a medical student or a resident or whatever, then it's probably already decided by the time it comes to you. You didn't probably put that gold bar on their chart. It just shows up. Boom. Now you got to figure it out. Maybe if you're a little higher up, you'll know that these VIP patients are coming in or know what it takes to become a VIP patient. But from my perspective, I really haven't been on the end of designating people to be VIPs. But we've all probably dealt with these VIP patients. And this article in the New York Times really just exposes a lot of stuff that goes on. And NYU was the target for this, but there's, hospitals across the country that engage in the same similar behavior, worse behavior. So, this isn't just talking about NYU. So basically, this article breaks down how different VIP folks, big time donors, friends and family of board members would, be able to text a private line, let people know that they're coming into the hospital, and they would then receive preferential treatment, being treated. They mentioned ER Bay 20, where they would put these patients. They'd be seen right away. They'd get rooms faster. And again, if you've worked in different hospital systems, you've probably seen some similar behavior. We'll dig into a little bit about the ethics involved with this. What is the problem? First of all, the preferential treatment, the different standards of care, is some of the big things that can happen where you have other patients that are not VIPs. There's the regular patients that go to the ER for care. And we know that the patients that seek care in the emergency department are oftentimes patients that do not have a primary care physician that they see routinely. They don't have regular scheduled doctor's visits. They come to the ER as their form of primary care. You don't have to have insurance to be seen in the ER. So it's a safety net for people that can otherwise not receive the care that they so desperately need. So when you add to the mix these VIP patients that just come in and jump to the head of the line, they're taking resources away from these people that are under-resourced, that this is their only shot at receiving this healthcare. Preferential treatment. So that's one big thing that's the problem. This directly can contribute to different standards of care and health care disparities, where you're taking resources away or delaying resources to this underserved patient population to go to the VIP. Also, there can be a different standard of care. You see some person, with a sore knee, you're just going to give them some Motrin and send them home. Well, if it's a big time donor or an actor, you're going to do a full workup complete with MRI, et cetera. So these different standards of care do exist and can significantly impact your practice and change the quality of care that patients are receiving. This problem, like I mentioned several times, it doesn't just exist at NYU. It exists at hospitals across the country. It exists in private groups. I mean, from jump, you could talk about private groups that are kind of more in tune to billing and finances versus the public hospitals that are, they receive tax breaks, and their mission and duty is to provide care for those that, are underinsured or lack insurance or have no other means to pay, these safety net hospitals, et cetera, like NYU is. And these hospitals that, don't necessarily depend on the insurance, sure, they're going to take all comers. But then you almost have this baked in to those private groups that obviously they're a business, you have partners, and as a private practice internist or orthopedic surgeon, you need to make that profit margin to feed your family, to take care of your office staff, et cetera. And you're going to be more in tuned to the insurance that your patients are bringing. If they can't afford your services, different insurances reimburse at different rates, with I think the lowest being your Medicare, Medicaid patients that reimburse at an extremely low level. I think that reimbursement actually just got cut in this newest iteration of the budget. So to the point that doing surgery on some patients with Medicare or Medicaid, your group may lose money versus going with a private insurer, Blue Cross Blue Shield, or something that pays better. Your group can make a lot more money, or at least break even or cut a profit, right? So it comes down to payer mix, and we see it all the time with anesthesia groups. I'm an anesthesiologist, so you have groups that are in wealthier areas. They have a better payer mix. Those groups tend to do very well. You can go to groups at the underserved areas or at community hospitals, community access hospitals, and oftentimes the anesthesia group is not profitable because they're going to be billing anesthesia. They're going to be billing Medicare, Medicaid for anesthesia. And so the hospital actually has to provide a supplement to pay for their anesthesiologists, their anesthesia staff, to ensure that they can continue to provide care to these patients. So that segregation occurs, right, from a private group to a public hospital. This was even present in the military, these different standards of care. I practiced for 4 years in the military. So there's actually a whole, I can't think of the name. It wasn't VIP medicine. It was, I think it was called the executive medicine branch of the military, where you have these high-ranking officers. I learned this in the military. So if you're like they call them flag rank officer, which starts at 010, what's it? 06, 07. So after like a colonel or a captain in the Navy or Army, a colonel in the Army and Air Force, full bird colonel, or a captain in the Navy is the 06 rank. The next up is 07. That's when you become an admiral or a general. And as you progress up that pathway, you actually get your own like attaché, your own person that just makes your appointments and drives you around. You have your own chef, all these like little perks, but you also get your own kind of medical staff. And there's this executive medicine branch that provides care exclusively for you. Obviously, the President of the United States has his own physician, has his own medical team. You go to DC or the Hill, there's different groups of physicians that are taking care of those folks. So you see there's levels to medicine as a point, as opposed to the boots on the ground, lower ranking troops that, you know, their primary care physician isn't even a physician. It's probably like a medic or somebody. And once that medic has exhausted their medical knowledge, they're going to, you know, refer to like a general practice physician, a flight doc, a general medical officer, whatever. And they're going to try to get into see the actual doctor. So there's definite levels in care that already exist. We know that. So it's interesting to highlight these disparities, especially as you're seeing at a huge academic center in downtown New York. I think about, you know, we can probably all think about the different patients that we've taken care of that were VIPs. I've taken care of a number of VIPs, folks that were big time donors to different hospitals that I've been at. Probably, you know, and I'm not very easily impressed, but I think there's, you know, some times where you do treat patients that you are like extremely impressed with. Maybe your favorite actor walks through the door, or maybe, you know, your parent's friend comes in, and there's a internal dilemma or a question like, how do you treat that person? Do you treat them the same as everybody else? And I think, you know, as I sat down and thought about this, there's a couple different things. There's one, the clinical practice. We should be providing the same standard of care based upon our medical training, based upon evaluating these patients as individual patients that we're seeing. But I think the other part of this is would kind of come under professionalism, and how do you interact with these patients? So if I'm interacting with a 17-year-old kid that broke his arm skateboarding, I'm probably going to be a little more casual. I'm going to relate more to that kid as compared to the President of the United States if they came to my operating room and I was providing anesthetic. So I think for myself, it would be a different level of professionalism, but it would be the same medicine. I would still perform a pre-anesthetic evaluation. I would provide the same medication, the same anesthetic that's tailored to that patient's needs. As I think about, you know, myself, how do I treat these patients, these quote unquote VIPs? And I always say tongue in cheek, all of our patients are VIPs. I provide the same standard of care to everyone that I am fortunate enough to treat.
Hey there. I hope you're enjoying listening to the show. I wanted to take a minute to talk about TrueLearn and thank them for sponsoring the Black Doctors Podcast. TrueLearn is a medical exam preparation company that helps you outperform on your boards. If you are a medical student or resident physician, you should definitely check out their products. If you sign up, please use the code BDPodcast and you'll get a discount. They have resources for both DO students as well as MD students and even physician assistants. When it comes to residency licensure, they offer question banks for over 8 different specialties. TrueLearn gives analytics that give you insight into your study habits, your question responses, and tracks you along with your peers. Students and residents average 20% improvements after completing a TrueLearn Smart Bank. Check them out at truelearn.com. And again, remember to use the code DDPodcast to receive your special discount. Now back to the show.
Then I think about, different standards in residency education, right? Because we have resident clinics. What patients are they seeing in the resident clinic? Are they seeing staff members, faculty members? Are they seeing patients with private insurance? Or are they seeing people that are underinsured and have less healthcare literacy? That's a situation that's been long running. Different hospital systems treat this situation very differently. But if you look around, that's very telling, and in essence could be a surrogate for what NYU is doing so blatantly. They're selecting and allegedly calling, people are calling ahead and saying this is a VIP. Meanwhile, a lot of residency programs are saying this patient population will be seen in resident-run clinics versus, seen by attendings. And, what level of supervision are you providing to those residents? Because, everybody needs to learn. We're all going to be, learners at some point, and residents are physicians, but they should be supervised. So if your hospital is not appropriately supervising these residents that are seeing these patients, then they are providing a different level of care. I think that's how I've been able to come to grips with that in my mind. Me supervising my residents should provide essentially the same level of care as if I was doing the anesthetic or the procedure myself. And then I would lean back on that professionalism and kind of clinical judgment, because there are certain patients that you would say, this is not a resident patient. This is not a teaching case. So I thought to myself, what does that mean, a teaching case versus a non-teaching case? And it's one thing to say this is a VIP and therefore I will do an attending only anesthetic. That is probably a little bit flawed once you dig into that. You are providing a different level of care because you want that resident to train on everybody else, but not on this quote unquote VIP. But I think the clinical judgment comes into play where, say, you have a medical malpractice lawyer whose partner comes in to deliver, they have an epidural placed. Do I want the stress of that person's profession to cloud the judgment or stress out the resident that I'm working with? Or do I, as an attending, step in and take on the responsibility of performing that task to spare the resident of the stress? And we can do something where the stakes aren't as high, where you may not feel as pressured. Same thing with the President of the United States, or somebody that I think may unduly influence the resident's judgment, may make them very nervous, more prone to make mistakes. Then I think there's a bit of professionalism and clinical judgment there that says, hey, step back. I'll just do this because that way if something goes wrong, that's on me as the attending. So I think, that's how I rationalize it. And that's how it makes sense, at least in my head. The one person that I've really just been enamored with or in awe of when I was in the Navy, I had a patient come through. They were a member of Naval Special Warfare and they were flag rank. So they were an admiral. And just being in this person's presence was just awe-inspiring because they were older. You just knew that they'd seen so much, like the national secrets, the things that had been done for better or for worse, and that they'd attained this rank that was so high. And then they had friends come in. Is always top secret kind of spooky stuff. But yeah, my resident did the nerve block for that patient. And because I trusted the resident was an extension of me. But that's how I would rationalize, who do I have the resident treat versus who do I step in and take over? So it would be kind of a slightly different level of care, but I think the motivation also makes a difference in explaining that to that learner that I'll do this because I just don't want you to take the risk or be stressed out or feel unduly pressured. I think that's partly our responsibility as attendings and chief residents or whatever the case may be. So again, the problem we talked about, preferential treatment and these different standards of care. I don't think the preferential treatment should not exist. This should maintain the same standard of care. And next, I want to talk about the stakeholders in this. because there's quite a few different people involved. And I think looking at this from their perspectives, different perspectives will help. So number one is the perspective of the patient. You have an emergency department full of patients that are in varying levels of sickness. Some patients have a cough or a cold. They can wait to be seen. Everybody's time is valuable at baseline, right? So jumping a VIP to the front of the line at the very least says that their time is more valuable than this other person's time. Is that true? In some situations, hear me out. I think, with the military, you have very high-ranking folks. You have the president of the United States. You have senators. You have people who, I guess we could say, the end justifies the means, that they need to be somewhere else and they need to kind of move through this system a little faster. But at the very least, you're saying that their time is more valuable than this patient's time. Taking it a step further, it's worse that this patient is very sick, and now you're valuing this person's health and well-being over that person's health and well-being, right? That's a tougher pill to swallow. So that's from the patient's perspective. As a VIP patient, well, you say to yourself, I donated $100 million to this hospital. By golly, I should be seen expeditiously. I don't know. I can't fault them for thinking that. My potential solution to that would be just making it a full, concierge type practice. At different hospitals I've worked at where there was the VIP kind of setup, when that text or whatever went out that this VIP patient was in the ER or headed in, well, then that patient's physician, who was, employed by the hospital, but was kind of under this little concierge heading, I guess, they would come to the ER and see that patient. So it didn't pull any resources, minus the hospital bed, which, at some point people would get an ER bed. I don't know how much of the line jumping that occurred, but that person's physician, who wasn't probably otherwise engaged in patient care because there's some senior ranking, professor or whatever, would appear from their office or wherever they were. They would come down, they would admit the patient, they would see the patient during their hospital stay, they would provide care. So you're not directly shunting resources from other people. The physical space, sure, but at some point, they would have all ended up in a hospital bed. So I think having that separation of concierge medicine versus we're going to bring this VIP person in and then take these resources from everybody else to them, I think that's one kind of more palatable way to address these issues. From the physician's perspective, you're getting a message that says treat this patient differently. And depending on your hospital system and where that message is coming from, there's different layers of pressure. Anytime that I hear from a non-physician that tells me how to do my job, I'm immediately digging my heels in. How dare this non-clinician say that, oh, there's a VIP, because what are they looking at? They're looking at the bottom line. They're looking at their hospital rankings, all those things that are financial, and yeah, they help the organization. But as a physician, I try my best to stick to the science, and it's between me and the patient as patient-physician relationship. So having this undue pressure coming from a non-physician, non-clinician is a huge problem. But oftentimes, right, as you have these leadership roles, they'll be filled by physicians, right? It used to be, these are physician leaders. They did an MBA, they did whatever, and now they're the head of the ER, or they're the CFO or COO or whatever. And now you have a colleague that is influencing you to provide differential care to some extent. And that's a little bit different of a pill to stomach, but you should realize that, there's some coercion, because at least in this story, the New York Times, there was this threat that you would lose your job if you didn't play nice in a sandbox and provide this expected treatment. So obviously that is wrong. It's nice as a physician to know that, in part it doesn't matter, but also like there's this factor of, I know patient A will complain and patient B won't. I'm not saying this is right or wrong, but I know this person that doesn't have insurance can sit and wait 5 minutes longer, and they're not going to complain. Meanwhile, I have this parent of this university student that if everything's not perfect, they're going to complain about everything. So not saying it's right or wrong, but it definitely makes my day a little smoother if I just put them in this room. If I go see them, I make sure I, have that extra level of professionalism, and provide that outstanding patient care. Same clinical practice, but I don't want to hear any complaints. So I think that's like some of what goes on. We know what patients are going to complain oftentimes, and we can kind of do our best to avoid that. So I think that's part of the perspective of the physician. It's sometimes nice to know that this patient's a big time donor. Maybe it's not. It shouldn't influence the care you provide, but maybe, you'll be a little more nice, I guess. Some of the VIP patients, the problem is that the care team will overlap. Even if you're being seen by their own concierge physician, the x-ray tech that comes through and, 4 a.m, they got to take x-rays, because this kind of happened to some folks that I worked with. And they're just going down through the ICU, shooting x-rays. And this particular VIP patient thought that they'd been like jostled extra hard, or maybe that person wasn't, having the best day, as they were taking x-rays all morning at 0400, and there was a complaint, and that person almost lost their job, and they're just the x-ray tech, So if they'd known, then maybe they would have like been extra gentle, I guess, although they should be gentle with everybody, but such is life. So that's kind of from the physician's perspective, and then the hospital administrators. And then we talked already about the other patients that you could be delaying their care, or potentially delaying very critical life-saving care to those patients. I already briefly talked about potential solutions, whether that's, having a concierge medical practice that does not take from the resources that are available to all of the other patients. But when it comes to this access, an important question for me, to determine, is this ethical or not? Is this other patient at risk for experiencing a worse outcome because I am changing the way I provide care to take care of this VIP? If you are in this system, and ultimately what kind of brought this to light at NYU was the ACGME. Residents actually complained and said that this was adding kind of undue stress to their training, and they felt pressured to provide this different standard of care. And the ACGME came in and kind of looked deeper into the program. I think they ended up potentially suspending the ER program at NYU, or some kind of action that made the university like stop and reconsider, how they were doing this. So yeah, if you are in a healthcare system, what can you do about it? One is, climbing that academic ladder, climbing that rank structure to where you're involved in hospital administration, to where you can change these policies and say, we're not going to put a gold bar on these patients. We're not going to provide preferential treatment to these patients. If you're a resident or trainee, I mean, the best thing I could do every time somebody said it's a VIP patient, I would say politely, all of our patients are VIP patients. And if you say it enough, you're actually going to start to believe it. And you should, because it's absolutely true. We need to be treating all of our patients with the utmost respect and professionalism, despite what admin says, or if they have a gold bar on their Epic chart. So once again, what are your thoughts on treating VIPs, providing different levels of care, different waiting times? How do you interact with these quote unquote VIPs? And if you could, what would you do to change things at your current facility? If you want to answer those questions or be a part of that conversation, visit our website, www.theblackdoctorspodcast.com. Click on the share the mic or pass the mic icon, and you can record your voice just straight from your phone or your computer or wherever. We can take that and then plug it into a future episode. Thanks for tuning in this week. Thanks for listening. Stay tuned. Next week is a new year. We're going to keep going. You're going to hear some great episodes, some inspiring content. We appreciate your support. We're here because representation matters.